Welcome to Legal Nurse Podcast. This is your spot to get inspiration, tips, stories, and guidance to help you in your legal nurse consulting practice. I'm Pat Iyer, the host of Legal Nurse Podcast since 2016. We are among the top 5% of all podcasts in the world in terms of longevity and sharing information consistently week after week with legal nurse consultants. Sit back, relax, and enjoy the show. Welcome to Legal Nurse Podcast. My name is Pat Iyer, and today we're going to focus on an area that gives rise to a lot of litigation, and that is obstetrical care. My guest has a master's degree. She is well certified in the area of obstetrical nursing and electronic fetal monitoring, and she works clinically as well as being a mom, a wife, and a legal nurse consultant. Maureen Elia, welcome to the show.
Thank you. I'm so happy to be here.
I know that this is a challenging area, Maureen, and one that draws attention to outcomes in a very high-risk part of nursing. When I entered nursing a long time ago, we didn't have electronic fetal monitoring. We had these big, heavy fetoscopes, I think they were called,
Exactly.
that were, like about, if you're watching this on my podcast, my fingers are about 3 inches apart. I remember they were very heavy, and we moved them around the abdomen and listened to fetal heart tones.
Intermittently, just here and there, kind of trying to figure out how the baby was doing, trying to figure out if it was a change in the baseline that you had heard when you listened 15, 20, 30 minutes ago.
And now that seems archaic compared to having a continuous electronic fetal monitoring strip running. For those who are watching this podcast on our YouTube channel or listening on our audio channels, tell our listener, what is electronic fetal heart monitoring?
Electronic fetal monitoring is essentially two different electronic monitors that we can either place on the abdomen, or if needed, we can actually place internal monitors as well after the patient's bag of water has been ruptured. And it allows us to either continuously or intermittently monitor the fetal heart rate as well as the uterine contractions during labor and even during the antepartum period to assess fetal well-being. The monitors can be used to allow us to detect fetal hypoxia or to detect fetal distress. And it helps us basically guide our decisions for if we want to do some interventions, if we need to do prolonged monitoring, and in some cases, if we need to expedite delivery.
It's a wonderful warning system of trouble and a comforting system when things are going well.
So true, so true.
I know that there is a whole science related to being able to interpret the strips. Can you give us a little sense of the concept of categories of strips?
Correct. The NICHD, which is the National Institute for Child Health and Human Development, developed these categories way back in 2008. They're basically three categories. There's category 1, which is strongly predictive of a normal acid-base balance. These are the strips that are not concerning in any way. They are a baseline of 110 to 160. You have moderate variability. You do not have any lates or variable decelerations. And when you're looking at these interpretations, you're basically thinking, this baby, this mom, labor is progressing nicely. Or if it's in the antepartum period, you are looking at this baby and you are thinking that everything is going well. On the other end of the spectrum, you have your category 3 tracings. These are abnormal. These tracings do give us concern that we could potentially have an abnormal fetal acid base status at the time that we're observing them. They require prompt evaluation and definitely interventions. They have a very strict requirement. There is essentially absent variability that is coupled with late decelerations, recurrent variable decelerations, bradycardia, or a sinusoidal pattern. With the category 3, we're going to be doing interventions simultaneously while we're thinking about delivery. So outside of those two, everything else falls under an umbrella of category 2. So in other words, category 2 is very broad, and nurses have to be able to interpret category 2 because on one hand, I can have a category 2 that requires minimal intervention. I'm not reaching out to a doctor and saying, hey, this is concerning. I feel as if we need closer monitoring. I feel as if, you need to be coming to the bedside. But I can also have a category 2 that I'm doing multiple interventions. I'm basically on the brink of a category 3, and we might be moving towards expediting delivery.
So it sounds to me like there's a lot of responsibility placed on the nurse for interpreting these categories.
Correct.
Is there any way or is there any equipment that alerts the nurse to the different types of categories? In other words, are the monitors sophisticated enough that if you're in a category 2, it sends some type of a message?
Oh, wouldn't that be something? So there is not that I know of. And I can't say that I know of all the different monitoring systems. However, some of our newer monitors are very helpful in helping you determine the different aspects of fetal monitoring. On our newer monitors, they have a tool on there that you can pull up that will put a nice little grid across your strip that you line up with your baseline, and that has these little boxes so that you can essentially look at all of your accelerations and see if they meet the criteria of a 15 beats per minute by 15 seconds long. In the same aspect, that grid that line that I was talking about, it helps you determine your baseline so that you can see where exactly along all of this variability am I seeing where my baseline is falling, which might help you determine if you're actually falling into tachycardia. Are you falling into bradycardia? So these different tools that are implemented into some of the newer technology could help you determine each aspect of your interpretation, which then, if you know the different criteria needed for a category, it would help you determine the correct category. However, it still falls on the labor and delivery nurse to know the correct definitions of each category. I don't know of any software that's going to say, if you check this box, this box, this box, it's this particular category. And I will say there is still a level of interpretation that comes along with, with each nurse who's reading their fetal monitoring strip. And when I say that, I will say that for, so while we have a definition of minimal variability and moderate variability, moderate variability is going to be 6 to 25 beats per minute, whereas minimal variability is going to be 5 or less. I can look at a strip after doing this for 13 years and having fetal monitoring certification and being an instructor and see minimal variability, whereas another nurse sitting next to me can interpret it as moderate variability. So I think that's another reason why there's not going to necessarily be a software that's going to come out and necessarily pick it for you, as we all have our own different interpretation. But that is part of why the NICHD came out with this standardized categories, this nomenclature for labor and delivery and all women's health care health team members to utilize, is to try to standardize the interpretation in order to improve communication among providers and basically remove that ambiguity in our clinical decision making.
And as you talked about it, if you're going from the difference between category 1 and category 3 with 2 being in the middle,
Yes.
it sounds like there's a continuum with some strips that are closer to a category 1 if they're in the category 2, and other strips, as you mentioned, that are verging and transitioning into a category 3 as
Correct.
the condition worsens.
Yes. So a category 1 has moderate variability. A baby could simply go into a sleep cycle, which would then go into maybe, a period of minimal variability. If it takes, if it's a period of time where my, strip check, my 30-minute strip check is minimal variability for the majority of it, that's a category 2 strip check. That is not concerning to me. That's not something that I'm going to then start implementing interventions, calling the doctor, start and have in the back of my mind, I'm concerned about this. I don't know if I need to escalate, my concerns. I don't know if I need to be thinking I have to talk to the charge nurse. I have to talk to special care nursery. I have to be thinking about a C-section. No. This is really honestly most likely a sleep cycle. The baby's going to pop right back out of it eventually. And this is on the end of the category 2 fetal monitoring strip that is very reassuring, a term that we don't necessarily use too often anymore. Whereas if I have a fetal monitoring strip at the other end of category 2, which could be fetal tachycardia up to 170, 180 beats per minute, minimal variability with very deep and prolonged variables. That's very concerning to me. It's not a category 3 yet, but I have a baby that's working very hard. It's demonstrating to me that it has minimal variability. We're going to absolutely have I'm going to be elevating my concerns to the provider. I'm going to be doing interventions like turning her on her side and giving her fluids and maybe reducing Pitocin if that's what I've been utilizing. I'm going to have the physician in the room talking to the patient about we've done this, we've done that. That's been this period of time, whatever it might be. And there might be a discussion about escalating delivery. It depends on what the rest of the picture looks like, the clinical picture looks like for the patient. But you can see how both of those are a category 2, but they give completely different pictures and completely different interventions. And the plan of care is going to be completely different.
You brought me back, Maureen, to a labor and delivery unit that I was in many years ago with my best friend's daughter, and her labor arrested in the middle of the night. And I remember the nurse midwife coming in and saying, Lori Lee, you are just not working hard enough. You've got to work harder. And that went on for hours. We were all sleep deprived. This by the time she delivered, we'd all been awake for at least 24 hours. And we were in that walking sort of fuzzy frame of mind of how do we even problem solve this? I'm thinking about, the nurses who are trying to interpret what's going on with concerned family members and a mother who's exhausted. You really need to be a great patient advocate and on your game to get that physician there. Because
Yeah.
my friend's daughter probably had at least 4 hours of labor that were unnecessary. She ended up getting a C-section done. As soon as the doctor came in, boom, she was in getting prepped and down the hallway for the C-section because of the fact that there was no more descent of the fetus at that point.
I hate to hear that there was any blame placed on her whatsoever. While the patient is absolutely involved in so much of their care, from the different position changes that we're doing to making decisions with us and being involved. And here's what I'm seeing on your fetal monitoring strip. We're going to do this. And what do you think about doing that? At the same time, I would never place any blame on anybody. Like there's so many different variables that go into whether or not we can achieve a vaginal delivery, and much of it is outside of the patient's control that That's just so sad for her because I'm sure that those words stuck with her for so long. Just a couple of words from that whole entire event probably stuck with your friend for such a long time. Unfortunate.
Yes. In working on cases with attorneys, I know that, and you've mentioned it so far in terms of late decels, is a phrase that as a med-surg nurse has got embedded in my brain. Tell us a little bit about the category 3 strips, the late decels. You mentioned also concerns about acid-base balance. Put that together for us, if you would, in terms of what are those concerning signs? What are they telling us if we're paying attention?
So a late deceleration is essentially telling me that there is an interruption in the fetal oxygen pathway. It's not, it's, so does a variable deceleration tell me that there's an interruption in in the fetal oxygen pathway. The difference is that with a variable, I know that it is typically cord compression. With a late deceleration, I'm not 100% sure where that interruption is coming from. So I'm going to try different interventions. I'm going to try turning the patient on their side in order to improve oxygenation to the fetus. I'm going to try a fluid bolus. I'm going to check maternal vital signs. Is she hypotensive? And I can improve oxygenation to the fetus by improving mom's blood flow. Am I going to check mom's oxygenation, see if she's running a little bit low and I need to apply oxygen? Is it that she's contracting so often that there's not enough rest, and that I need to allow resting time in between the contractions so that the uterus can refill with blood, that gas exchange can be happening, and that then this baby can get more blood? Is it that when I palpate her abdomen, that maybe her uterus is resting in between contractions, but it's not really rest? It's actually still pretty taut and tight, and that I need to figure out why isn't her uterus resting enough. There's so many different variables that we can look into to figure out or to try to navigate what it is that is causing these late decelerations. After we've gone through everything in our wheelhouse, if we can't figure out what is the cause of the late decelerations, that's when, by this point, you should have already had your physician keyed in on, this is what I'm seeing, here's what I'm trying. Is there anything else that you want to try? Because you're never alone in this, right? We're a healthcare team. That's when the physician should be stepping in and basically be saying, here's what we're seeing on the monitor. We're concerned. We've tried this, we've tried this, we've tried this. And much of that plan of care is going to become, how far away are we from delivery? If you have a patient who's dilating rather quickly and we think that we're going to, and it's maybe not her first baby, and we think we're going to be delivering in the next hour, some of the picture is going to be determined by her variability. But if you have a patient who's maybe remote from delivery, we're losing variability, that's definitely a patient that they're then going to start talking about a C-section with. Now, you had asked me how the lates correspond with like a category 3 strip. Ideally, we want to catch things. We want to be interpreting. We want to be applying interventions long before we get to a category 3. You do not want to be seeing category 3s in the hospital at all unless the patient presents in a category 3. If we've allowed it to continue to progress from a category 2 to a category 3, I think we've potentially waited too long in whatever it is that we were trying to fix. So a category 3 is that absent variability with recurrent variables, lates, bradycardia, and then finally a sinusoidal pattern. At that point, there's not going to be a lot of time spent. There's going to be some interventions happening, but while part of your team is doing interventions, the other part of your team is notifying NICU or a special care nursery or any additional staff that you might have. They're setting up an operating room, they're notifying anesthesia, and you're really moving towards delivery. And it's so important at this time that somebody is making sure that they're keeping both the patient and her support person, whoever that might be, her husband, the father of her baby, her mother, her sister, somebody really informed, because it can be very traumatic for them to see a large amount of healthcare members be swooping in, which is often what it looks like during a category 3, to be maybe starting another IV, or to be hanging a bag of fluids, or to be unplugging her bed and unplugging her monitors and swooping her to the back. They need to understand kind of what's happening, what people are seeing, what the reasoning is behind it. So I hope that kind of answers your question. Do you think
Mhm.
that I kind of hit on it all?
You did.
Okay, good.
You did. And as you're sharing the implications, I'm thinking, as an expert witness, you've been asked to look at cases involving poor outcomes. What are some of the ways that this system breaks down? In other words, you've talked about how everybody works as a team and everyone is communicating, but I bet that doesn't happen all the time.
I think the biggest thing that I see, or the most recurring theme when I'm reviewing cases, is way back to what we started with, which was the interpretation. Part of my part of the work that I do when I review cases is I first go through the chart and see exactly what the patient presented with, what the plan of care was, and how her stay at the hospital went. But the second part is reviewing the fetal monitoring strips, and I go literally 30 minutes by 30 minutes reviewing what I feel the fetal monitoring interpretation should have been and what it is that was charted by the nurse. Coupling along with that, I look to see at what point was an intervention done, at what point was a physician notified, at what point was a decision made. And more oftentimes than not, any of the cases where there was a breakdown, it starts way back with the fetal monitoring interpretation being incorrect. And so if the fetal monitoring interpretation is incorrect, that's where we fail to have interventions done because we presume nothing was wrong, or we failed to notify a physician because, again, we interpreted that nothing was wrong, or we failed to alert a charge nurse or a NICU that, hey, I've got this baby. I just want to let you know I've got this patient, in room 2, I've got this fetal monitoring strip that's rather concerning to me. I have a feeling we're going to end up doing a C-section. I have a feeling that I'm going to have a baby that's going to need additional support. It all starts back with that fetal monitoring interpretation. So I really feel that for labor and delivery nurses who, oftentimes reach out to me saying, I know you do, med mal review. I know you review cases. What is it that I can do to protect my license? My number one answer is always be a constant learner and be always trying to improve yourself and make sure that you're on the top of your game, because no amount of documentation is going to improve if you don't know what it is that you don't know. So let's say that, much to what you brought up, the communication, that we are interpreting the fetal monitoring strip correctly, then it becomes, are you letting somebody know? I have had a few cases where the nurses have let maybe the charge nurse know, and they have done some interventions, but they've let it go there. And they've even stated within like their depositions, well, this physician doesn't like us to call, or this physician, isn't available, for whatever reason. We have to feel empowered to let someone else know, because you're doing all the right things if you are able to correctly interpret it and you're doing the interventions. But now take it a step further and let someone know that you're concerned and that you feel as if someone else needs to be coming to the bedside to make those decisions that ultimately, as nurses, we don't have the power to make.
I know that you mentioned that you're an instructor in teaching people about interpreting fetal monitoring. Is there a standard curriculum that's used, or is it done according to whatever the local facility wants to provide in terms of education, or is it online? I mean, how do labor and delivery nurses learn how to interpret strips?
So I can actually answer that in a couple different ways. I teach locally through a college, community college nearby. they utilize the same NICHD terminology and nomenclature in order to teach exactly the standardized language. However, I also am an A1 fetal monitoring instructor, and so we teach the exact same way. Through work, we take a GE fetal monitoring class every 2 years to remain demonstrating our competency. But again, it's the same standardized literature. So to try to speak to your point, I feel as if the majority of educational programs, certifications, any type of I'm trying to think of what I want to say, but they're all using this NICHD standardized EFM definitions in order to ensure that we are just basically removing any type of ability to misinterpret or to make mistakes, no matter where you would go and interpret a fetal monitoring strip.
And real quickly, a clarification of a couple of abbreviations. You said A1. Can you spell that out?
Absolutely. A1 is AWHONN, and it is the Association of Women's Health, Obstetric, and Neonatal Nurses.
And GE is for General Electric?
General, I believe it's General Electric. They have a series of fetal monitors themselves, and they have also put out education for women's health nurses, and they have fetal monitoring. I don't know, I would guess I would call it recertification that I know my organization utilizes every 2 years in order for us to demonstrate that we have the understanding of the NICHD categories, nomenclature, interpretation, etc.
So if an attorney were involved in a case and a legal nurse consultant was assisting, then it sounds like part of the discovery process is to look at the credentials of the nurses who are taking care of the patient, the defendant nurses. Were they certified in fetal monitoring? Had they kept up their recertification if that was required? What type of program did they go through? Was it a community college? Was it something else? Is there?
Absolutely. Yeah, that's one of the first questions they will ask, especially in a deposition. They ask where you went to school. They ask what type of training your organization offered you once you were hired. And then they ask what type of training you have done, either through your organization or on your own, to maintain competency in fetal monitoring. So some things you are offered through your organization, but I know myself personally, I do a lot outside of my organization because to me, I just feel like there are many great offerings out there, and I don't believe that there's any hospital that's able to provide all the different great offerings that they have out there. I really enjoy going to see some of the really great educators that we have available within our field. Lisa Miller, Rebecca Seifer, the critical care and obstetric staff. They put on some great conferences, all over the United States, but they also have webinars available, and they have little Zooms that you can join. They have books that are out, and it's just great to keep up with, kind of what's the latest in our field.
I know that this is going to stimulate some thoughts as people who are listening to this program get an OB case and they go, what was that nurse again who talked about fetal monitoring? How do I get in touch with her? What would be the best way for them to reach out to you, Maureen?
Absolutely. I have people reach out to me all the time, and I love to either set up a Zoom and chat, or just, they can just email me too. But that probably the easiest way is I'm on LinkedIn. You can find me just by searching my name, Maureen Elia, and my last name is Elia. Or I do have a webpage if you want to go through that way, that has all of my contact information. It's ME Legal Nurse Consulting.net, everything spelled just the way it sounds. Or you can always just email me too. It's maureen.elia, rn@gmail.com. And I'm happy to help anybody with any type of, endeavor they would like to look into between, getting started being a fetal monitoring instructor or just being more involved on their unit. Or I'm lucky that I have multiple different, my hand in a couple different pots related to obstetrics, but I love all of them. So there's never a day where I wake up and I think, oh my gosh, I have to go to work today. Outside of missing my family, which does stink sometimes, I really just love all the different things that I do and being involved in this sector of healthcare.
Well, thank you so much. You have brought up some great points. This is, as we said in the beginning, an area where there is a lot of focus on litigation. No one wants to have to take home a child who didn't get the best possible start.
Yes, I agree.
And we know that some deprivation of oxygen at a critical stage in that fetus's transition can make a huge and permanent difference in the lives of the parents and the child. So it's definitely an area that attorneys look at to see if everything was done appropriately during that difficult time. We have a relative whose child was born with cerebral palsy about 47 years ago in England. And it was a case where the physician was not in the department and the nurses tried to slow down the mother's delivery by holding her legs together so she couldn't deliver. And the child ended up being catastrophically injured. He can't speak. He can't write, he can't feed himself, he can't walk, he can't toilet himself. He requires attendant care. Tremendous implications for him. There was a lawsuit in England, and his family was successful in recovering money that was put into a trust. So his needs are taken care of, but it has been catastrophic for his family to be involved in his care and to see all the problems that resulted from what happened during labor and delivery.
I'm so sorry. Yeah, that's very difficult.
Yes. I would like to leave on a happy note, but that did come to my mind as I think about what happened in the long-term care of a child. It's not just the immediate, it's the rest of your life. There are things that happen, responsibilities that occur, need for respite care, a whole host of problems when you have a catastrophically injured fetus. I encourage our listeners who have OB cases, need an expert witness, contact Maureen. She is available and would love to talk with you to see if it would be a good fit for what you're looking for and the kind of cases that she can review for you. So be sure to reach out to her.
Thank you. It was nice being here, Pat. I'll come back anytime.
And we hope that you, as the viewer or listener, will come back anytime as well. Hang on a few more minutes to find out what's coming up next on Legal Nurse Podcast. And be sure to go to podcast.legalnursebusiness.com. We have now organized all of our 600 plus podcasts. This is now number 640 something podcast, where you can get the transcript, the audio, and the video if it's available. And it's sorted into categories so you can focus on just what's of most interest to you. Thank you, and I will see you on the next podcast. Coming up next on Legal Nurse Podcast, you'll be able to meet Karen Buxman, who is a nurse and a neurohumorist. Need to watch the show to find out what a neurohumorist is and why it's so important to maintain your sense of humor as a legal nurse consultant, as a nurse taking care of patients in healthcare. Sometimes the situations that we get into in the clinical area or in our business demand that we maintain our perspective. Karen, tell our viewer or our listener, what are some of the topics that we covered in your show?
We talked about the effect of stress on the brain and how it can affect us when we're dealing with conflict. We talked about the ways that humor can help us to de-escalate those situations as well. We talked about the use of sarcasm. You may be surprised about that. We also looked at what are the various things that can cause us to go into brain threat. And we also talked about some ways that you might want to look further into how you can use humor in your practice.
Stay tuned and be sure to come back and watch Karen Boxman's podcast. It's available on YouTube, on the Legal Nurse Business channel, or on audio channels. You will find out how Karen's behavior alerted an entire convention center that something drastic was happening to her, and you'll need to find out what that was by watching the podcast on Legal Nurse Podcast coming up next.